kind of the big topics that comes up over and over again is conversations about DNA CPR or end-of-life decisions. DNA CPR stands for Do Not Attempt Cardiopulmonary Resuscitation. If a patient's heart or lungs stop functioning, we are not going to attempt to restart them. Delivering CPR or cardiopulmonary resuscitation is a treatment in itself, and it's a very traumatic and harm-causing, as medical staff do not offer this treatment to people who we think will not benefit from it, or if they do survive, will have a poor quality of life after treatment. So if you do survive CPR, you need to go to ITU or HDU. And a lot of the time, the kind of clash between the medical professionals and the patients or their family about this topic is a lack of understanding of what CPR actually involves. You know, what percentage of people actually survive something like CPR. We end up having a lot of quite difficult discussions around this topic, which is obviously quite sensitive, quite emotional. People feel very strongly about these things.
So I did palliative care in my residency for 2 months, I think. So quite the contrary, I kind of like enjoy having this type of conversations, you know, be empathic, be human, and see what people coming from. I kind of enjoy having that conversation. I'm not enjoying people suffering or anything like that, of course not. But basically, I don't mind having these conversations, and I would love to engage in this type of conversation when it's actually really serious, and have engaged it multiple times. What I feel personally is initially it was really tough because English is not my first language and the different in culture. So there's a different perspective on a lot of things coming from the DNR, DNI. But I've seen that conversation many times again because I did 2 months of palliative. That's really helpful. You get used to it. And there are just a very, very basic framework that you can do to help. So you basically try to address the goals of care. What's the goal? Is the goal is getting better? Is the goal is actually to see your grandson graduate? So we're going to have to address that goal, what the patient know about their situations, about their medical conditions. And then you can try to move and steer conversation in that direction. Look, I don't think based on what you're saying, you understand about your medical conditions, you're probably not going to get better, you keep getting sick and then coming back to the hospital. I think it would be best for you to not have resuscitations because I think it will not benefit you in any way. And you talk to the whole family and then try to get perspective for each one. I experience it very often during my residency, and there was a lot of amazing, interesting conversations. Everybody's different. This is why the part that I quite enjoy in medicine. If you watch my previous video about how I answer my interview questions, I'll put the link down in the description below if you want to watch it. I mentioned that I enjoy problem solving. That's the reason why I enjoy internal medicine. I enjoy working on math, physics, chemistry, and enjoy doing USMLE questions. Yeah, but these are just things on paper. And then after I teach USMLE for like almost 2 years every day, 365 days every day, things get a little bit boring because it's going to be pretty much same thing. It's going to be the topic about choosing stress test. Again, it's going to be the topic about cause of pericarditis, giving colchicines or NSAIDs. It's going to be about differentiating Dressler syndrome with, it's going to be those again and again and again. They're just going to repeat pretty much the same thing because those are what they like to test you on. But when you come into real life, that is very interesting because the dynamics, not every diabetes patient is the same. Not everyone with hypertension are the same. You see all these dynamics, the difference. And as I become an attending, actually, I quite enjoy it more. There's a lot of variations, endless possibilities, endless situations that you really need to put your brain to think instead of using some kind of like a pattern recognition. So in the USMLE, it's kind of like pattern recognition. But here, you have kind of like a break the pattern a little bit. And you need to be able to really use your brain and then creativity to actually, okay, why don't we try this way? And you make that decision based on understanding of pathophysiology, physiology, and all your knowledge, and you make the decision for the patient. I make a lot of many random, not on so much textbook types of decisions. And then discussions about the DNR, DNI, so many things you can see. If you love to work with people, you're going to see so many different backgrounds or story that they have, and somehow this conversation enrich you, enrich your knowledge, is enrich your experience. You learn because the best teacher for you will be your patients, and they're not only teaching you disease. They're not only teaching you disease. They teach you many things about life. So these conversations about the DNR things, I actually quite enjoy it.